Hello, I hope everyone is fine, good, all healthy. Today the topic that we are discussing that is approach to precocious puberty. That whenever a child with precocious puberty arrives at your clinic, how will you approach that child? So what is basically precocious puberty? Precocious puberty is when children body that begin to change into adult bodies too soon before they are supposed to. So whenever a child with precocious puberty that arrives at your clinic, so what are you supposed to do? The first and the most important thing that is wiper in every examination, in every short approach, in every short case or anything. The first important thing to remember that is wiper. W for wash hands with sterilizing solution, warm your hands. I for introduction and rapid building, P for position the patient, E for exposure, and R for right side to approach for examination. Okay, now there's some steps for how to approach a child with precocious puberty. The first one that is the general look. The second one is gait, anthropometry, and back. Third one is the relevant GPE. The fourth one is genitalia and abdomen, and the fifth one is lower limb. So first of all, in the general look, we have to look for some things in order to rule in, rule out some diagnosis. The first thing that to do is stand in front of the child and look for some important things like for some dysmorphism in McCune Albright and Russell Silver. There is a kind of dysmorphism and any wound facies will present if there is any adrenal pathology, any hirsutism, muscular growth, acne, pigmentation, and respiratory rate. Now have a look at this. This is McCune-Albright syndrome that has a triad of precocious puberty, capillary spots, polyostotic fibrous dysplasia. So here is a child, here is two children, three children with McCune-Albright syndrome. They have capillary spots. In neurofibromatosis, the children also have capillary spots, but the difference is that in McCune-Albright, the capillary spots don't cross the midline and they do not have proper regular margins as in neurofibromatosis. So if you find any kind of dysmorphism in a child with precocious puberty, so keep in mind McCune-Albright syndrome. This is a baby with Russell Silver syndrome. They also have precocious puberty. The children who present with Russell Silver syndrome have precocious puberty mostly. Now you can see the two pictures showing acne and hirsutism. Now the second thing to note that is the gait, the anthropometry and the back. What you will look at the back for, you will look for any capillary spots or any scoliosis. And in anthropometry, there's important things that you have to measure. The first thing that is the height. If there is a child who presented to you with precocious puberty is short in stature, he has a short stature, so you can roll in Cushing, hypothyroid, neurofibromatosis 1, Russell Silver, long-standing precocious puberty. But if a child presents with precocious puberty and is tall, so he might have McCune Albright and recent CH. But if a baby has arm span greater than the height, so then that is a growth spurt. Okay. The second thing to measure that is weight. If a child with precocious puberty has increased weight, so he might have Cushing and hypothyroid. Then the third thing to measure that is OFC. So it is increased in hydrocephalus and intracranial tumors. So most children with presenting with precocious puberty who have increased OFC most probably will have intracranial tumors. Okay, now the third thing that is relevant GPE. So in relevant GPE, first of all look for the hands, to look for the pulse and the nails. Then check the BP, the blood pressure. It is increased in tumors as well as in 11 hydroxylase deficiency. Look for the arm and axilla for the BCG scar and the axillary hair. Look for the eyes for any cranial nerve palsies. Make an age to find out that all the nerves are working and are functional properly. And then look for the thyroid for goiter. Fourth thing to look for that is the genitalia and the abdomen. Seek permission to expose the breast and the genitals for the tender staging. Look for the testicular volume, the length of the penis, and then look at the abdomen. A skin pinch for hydration status and palpate for any mass like hepatoblastoma, ovarian, or adrenal mass. Fifth thing to look for that is the lower limbs to check the reflexes in order to check for upper motor neuron signs and the edema. Now, what will be the differentials if a child with precocious puberty presented to you? So, it will be either central or peripheral. Central is the true precocious puberty and is gonadotrophin dependent, whereas the peripheral one is gonadotrophin independent. Okay, now central precocious puberty will either be idiopathic, that may be familial or non-familial, or it may be due to the intracranial tumors, for example, hypothalamic hematoma, craniopharyngioma, astrocytoma, and optic glioma. Other CNS lesions like hydrocephalus, arachnoid cyst, traumatic brain injury, cranial irradiation, post-infection, any hematoma, or secondary central precocious puberty, which means that early maturation of hypothalamic pituitary gonadal axis due to the long-term steroid exposure, for example, CH. Okay, the second one that is the peripheral precocious puberty, and in that the first cause that is gonadal. That may include McCune-Albright syndrome or any ovarian tumor like benign cyst granulosa cell tumor or testicular tumor or familial testitoxicosis. The other cause that will be adrenal, like adrenal tumor and CH. And the third one that is HCG secreting tumor, chorioepithelioma and dysgerminoma. So we have two types of precocious puberty, two differentials for that, the central precocious puberty and the peripheral precocious puberty. The central one further has causes like idiopathic or some CNS lesions or intracranial cell tumors or secondary central, whereas peripheral include gonadal and BCG producing and adrenal. Okay, now what will be the investigations that you have to do for it? So first of all, you have to establish whether the child has precocious puberty or not. For that, what will be the investigation? In boys, you will do the midnight testosterone level, and in girls, you will do post breakfast estrogen level. And if both of them are of pubertal value, that means that the child has precocious puberty. And then you have to check the bone age, which will be advanced. Now, once established that it is the precocious puberty, find out whether it is central or peripheral. For that purpose, you will do LH-FSH and that will be increased in central. Now, once you have established that the child has precocious puberty, it is central, peripheral, now you have to identify the underlying pathology. So, in order to find out the cause for the central precocious puberty, both in the boys and girls, you have to do CT MRI for any tumor or any mass. For peripheral, now there are different investigations. For in boys, if there is peripheral precocious puberty, then what you have to do, you have to do serum androgen levels, for example, 17-hydroxyprogesterone, androstenedione, and DHEAS. Similarly, in urine, you have to go for the steroid profile, the sex adrenal steroids, and then pelvic and abdominal ultrasound for any testicular tumor, hepatoblastoma, or adrenal mass. And then the DNA study for G protein pathway to find out for McCune-Albright syndrome. In peripheral precocious puberty in the girls, what are the investigations? Bilkul similar to that of the investigations done in boys for peripheral precocious puberty. You have to do the serum androgen levels, urine for steroid profile, pelvic and abdominal ultrasound for ovarian tumor, hepatoblastoma, adrenal masses, and DNA study for G protein pathway to find out the cause of McCune-Albright syndrome. Treatment: multidisciplinary approach, parental counseling, and specific therapy. If it is central precocious puberty, then the treatment will be long-acting gonadotropin releasing hormone analogs, surgery, chemotherapy, and we have to reduce the sex steroid synthesis. And then you have to monitor it. How will you monitor it? You will monitor the growth rate, the pubertal stage, LH and FSH levels. And here it comes to an end. I hope your concept is clear how to approach a child with precocious puberty. Thank you.